Hi, everyone. I don't know if we have any participants yet. I don't see anybody new. So maybe we'll just give it a minute. Otherwise, we're going to be talking to ourselves. Hopefully, we'll have some people joining us. We have no one else. But we're being live streamed, so maybe people are watching us, and I should be starting. I just make sure, though, that we can. Stanley, we lost him for a minute, and he's rejoining us, one of our panelists. So maybe I will just start again. Welcome, everyone, to this session on Slipping Away, a review of gaps in capabilities for humanitarian cholera response. My name is Manisha Thomas. I am one of the co-authors of the report that was launched several months ago. So we're going to be talking about things that we researched a while ago, but we do have a colleague from WHO who can provide us with some of the more recent updates of where things stand in terms of cholera response. The report was funded, by the UK FCDO through the UK Humanitarian Innovation Hub. And this session is jointly organized by the Humanitarian Innovation Hub and Humanitarian Outcomes, which published the report. The theme of this year's World Water Week is Seeds of Change, Innovative Solutions for a Water-Wise World. And innovative solutions are something that the UK Humanitarian Innovation Hub and FCDO invest in quite a bit. So the hub has worked with Humanitarian Outcomes to deliver this research around some of the concerns about the global capacity for cholera response and control, and to see whether some of the past progress around cholera response has been lost. The report forms part of the overall rapid response initiative of the UK Humanitarian Innovation Hub, funded by FCDO. It's a new humanitarian research program that's got the aim of generating some new data and insight to support responses to new or deteriorating humanitarian crises. So thank you firstly to World Water Week for providing us with this platform. Just if we have any participants, which I don't see that we have any, but if you're here as participants and not just watching us live stream, you can introduce yourselves in the chat so we know where you're coming and joining us from. You can obviously mute or unmute yourselves, although I don't know if you have that capability, but we are going to be recording this event in accordance with World Water Week's terms and conditions. So we're going to first take a look at sort of the overall report, and then we're going to have a little bit of a response about what's kind of changed, and then take a look at sort of the situation in Malawi. So it is my pleasure to introduce our speakers. Nigel Timmins, one of the co-authors of the report with me. Nigel, welcome. And Nigel is a consultant who will talk about the report findings. We're then going to hear from Henry Gray, who is Global Cholera Incident Manager at the World Health Organization. And last but not least, we're going to hear from Stanley Chitukwi. I'm going to get it wrong, Stanley, I apologize again. Chitukwi, who is the CEO of the Organization for Sustainable Socioeconomic Development Initiative in Malawi. And Stanley's going to provide us some reactions from a practitioner's perspective on the findings of the report, and also what's happening a little bit in Malawi these days. So Nigel, I'm going to turn to you first to talk to us a bit about the report. What are some of the recent trends around cholera, and why was the report undertaken in the first place?
Hi, thanks, Manisha, and good morning, everybody. So if you look at things over the long term, there has been a gradual reduction in cholera rates. So compared to some decades ago, rates are not that high. However, within the last couple of years, there's been more countries experiencing cholera outbreaks. There were 27 in 2020, then that rose to 35 in 2021, 30 last year. And often in countries which had not seen cholera in a long time. So we had the usual cholera endemic locations, but also some new locations. But of particular concern was the case fatality rate. Cholera is a relatively easy disease to treat, and you would normally expect case fatality rates of under 1%. But we were seeing much higher rates. For example, in Mozambique, it reached 3.3%, even 4% in some districts. And so that raised questions about the global capacity for cholera response and control, and whether some of the progress made in the past had been lost. In fact, it was, in a number of the humanitarian response countries, so countries where there's a humanitarian response plan, there have been cholera outbreaks in over half of them. And so what is the capacity of the system to actually respond well to cholera outbreaks? Cholera has long been considered a basic competency for humanitarian agencies, and it was the disastrous performance in Rwanda in '94 that led to significant shake-up in the system in terms of developing quality standards and accountability commitments. So the review set out to ask, 3 decades later, how is the system responding? Now, there are lots of reasons why cholera can break out, because of underlying issues such as armed conflict, development challenges, governance failures. Climate change is increasingly seen as a driver, and those are obviously beyond the role and influence of humanitarian actors. So this review focused very much on the response element, the humanitarian capacities, competencies, and coordination. And it was this rise in case fatality rates from a disease which experts agree no one should die from that really raised questions that we felt needed to be investigated.
Sorry, I realize we don't actually have anyone joining us on the chat in Zoom. We have to go through the platform chat. So I was trying to find my way to there, but I haven't managed to get there. So apologies for anyone who's posted a question yet. I will try to find the chat while I ask Nigel the next question. So Nigel, can you tell us a little bit what were some of the key findings of the study?
Sure. I think a key issue was sort of how the overall system is coordinated and driving things forward. So the global entities leading on cholera, notably the Global Task Force on Cholera Control, have, by all accounts, the people we spoke to made great strides in marshalling consensus and capacities of national and international actors towards some common goals. However, only 2 countries, and I checked last night on their website, only 2 countries have implemented the response plans so far and sort of been signed off. 3 more are pending. And so, although the commitment is there, in practice, we're seeing less action. But even then, response to cholera is not a responsibility of the Global Task Force, which is focused on the eradication of cholera. Response falls more to the health and WASH clusters, and to the Global Outbreak Alert and Response Network, which plays a role in providing technical support and capacity. There's also a challenge of, there's a challenge of the coordination between the clusters as well, which obviously interacts with a number of different implementing partners, from ministries of health to different operational agencies, but also in the amount of available adequate technical capacity at the World Health Organization and its partners, including national governments. And we frequently heard of concerns about capacity at national and local government level, and how that works across the health sector, but then linking to WASH, which is often distributed across multiple ministries, from ministries of infrastructure to agriculture to urban municipalities, for example. In addition, lots of agencies talked about a loss of WASH capacity. And that often this WASH feels very underfunded, and WASH solutions can be passed over due to a focus on short-term funding solutions, when actually to really improve WASH situation, you need larger term sort of capital investments. So again, this recurrent challenge between water trucking and investing in long-term WASH capacity. And finally, a key issue is around the poor levels of reliable data at global level, but also the operational level. And sort of misaligned incentives have led to both over and under reporting of cholera, and also slowness in reporting and confirming cholera, leading to delays in response, which has allowed the disease to grow and spread.
Thanks so much, Nigel. And I think, we did do the report quite some time ago, but obviously, hopefully, things have started to improve a little bit. I know, Henry, you've just been, or not just been, maybe you've been recently appointed, I think, in that role as Global Cholera Incident Manager. What's changed a little bit since we put out the report a while ago? I was trying to remember what month it was, but I haven't found it yet. But it's been February. Since February, what sort of changed in terms of the kind of the response to cholera?
I suppose there's a few things that have changed. I mean, WHO and its partners, particularly UNICEF, have we've noticed these changes in terms of outcomes, the deteriorating case fatality ratio, the fact that we've got more countries that have reported cases last year, and this year we're on for a new record. We've noticed these things, and we've upgraded in terms of our global risk assessment for cholera. So within WHO, it's now internally as it's a global risk basically. That's not to say that it's going to affect all countries across the globe in the way that COVID did, but certainly we've got alerts and cases in 5 of the 6 WHO regions, and we've had alerts in the 6th region. So we're definitely seeing this this global spread of cholera, that it doesn't matter if it's 50 cases or 500 cases or 5,000 cases. It still requires the same level of response in terms of setting up structures and supporting countries in their battle against cholera. So I think that's where for WHO we looked at this increase of risk, the fact that our case fatality ratio is high, and so we were like, we need to do something a bit different. So we have set up this global headquarters incident management team, which is there to support countries, but also regions, and then also partners. So within that HQ support team, we also have embedded people from UNICEF. I think we have 5 or 6 people currently sat on that team, so that we have a bit more of a joined up approach with our friends from UNICEF. This is partly driven by a shortage of resources. Money, first of all, it's not all about money, but a lot of it's about money. Materials, so cholera response materials, the cholera kits that WHO, UNICEF, and many of the case management partners use, and then also the oral cholera vaccine, shortage of that. And so with this kind of global shortage of HR, of vaccine, of normal cholera material, we needed to get together so that we make it as efficient as possible, so that UNICEF isn't buying material, that WHO is also buying material, sending it to one country, which will basically then mean that other countries are not able to receive. So the shift was in reaction to that. I think the bigger point here is that this response effort is hampered not only by a lack of money, by a lack of preparedness, and obviously by a lack of prevention. Nobody should be getting cholera. That's the bottom line. Response is it's the end of the chain. We don't have money or resources for preparedness, so we can better respond. So we're always late when we do get to respond.
Super. Thanks so much, Henry. And I guess that question, about the lack of preparedness and prevention, how the funding isn't going into that. I mean, during the COVID response, there was the emphasis on a lot of things around WASH, the thought that there would be more investment in WASH, that we would be making sure that those systems would be built up in a proper way, which would lead to that sort of prevention and preparedness. Where has the kind of global emphasis on, good water and sanitation, is that just no longer a priority for donors or countries, or where's that kind of gap gone, or where's that gap coming from?
I mean, that's a really good question. I mean, WHO and UNICEF, we put together our strategic preparedness, prevention, preparedness, and response plan. For WHO, it's around 160 million. UNICEF call to action, 480 million. That's for 12 months response to cholera. They're not funded, but basically 0% funded. So we can't even get people interested in life-saving response. Preparedness, there is just no money. The funding mechanisms that are open to WHO and UNICEF and other partners, SURF for all the UN agencies, CFE for WHO, is specifically for life-saving response. We can't use that for preparedness, and we certainly can't use it for prevention. I think everybody agrees that money spent on prevention is far better than on response. You know, it is, but the problem there is that we're not able to use that the funds aren't flexible, so we can't use response money for preparedness or prevention. Whereas, you know, that with the data we have, we should be targeting our hotspots and kind of throwing resources at those to reduce that risk of cholera. But we're not able to because we don't have that flexibility in the funding. And the last thing, just on the data, Nigel mentioned it very clearly in his opening remarks, is the data is really, really poor. We cannot get good data. One example, which is actually it's great that we've got representatives from Malawi, is we got good data from Malawi, but for countries that particularly in the Eastern Mediterranean region, but also through the African region, we're just not getting enough good data to help us better respond.
And I'm going to go to Stanley first, then I'll come back, maybe Henry, on that point about the lack of good data, because I think that's constant. It was one of the things that we found also, I think, in the report about we're not getting the reporting there. You know, what are some of the investments that need to be made in order to get that good data? But maybe, Henry, I will come back to you on that one, because I'm going to let Stanley come in to make sure that he's got a chance, because you were also mentioning that you do have good data from Malawi. So maybe, Stanley, from your perspective, you know, what did you think of the findings of the report compared to what you're seeing in Malawi now?
Right. Thank you so much for such opportunity to share some insights in Malawi, and even also the global perspectives. As of now, we've seen there's a low decrease of the cases of cholera in Malawi, but it's still in some parts of the country, it's still hitting, according to the report right now. We are still like about more than 10 districts are still hitting with a low pace of cholera cases, which are still being treated. And one of the issues that I really looked at it in Malawi is there is a good coordination at a national level, and there is a weak coordination at the district level and the community level is not all that good, because there are a lot of data that has been collected from the communities, and this data has got a lot of discrepancies, and some are not accurate in terms of the analysis, how we are going to present. That it seems not to be presenting the margin of what is happening on the field. And when you look at one of the presenters last time, he presents some data which has happened that the data was not the accurate data, was a Cook's data. So I think in terms of the data in Malawi, there's a need of strengthening the capacity of all the stakeholders to collect the data efficiently and to the right people, so that the data that we're going to report globally as a trend of cholera must be reflecting the true picture. Could be one of the issues of the data could be the technical know-how, and also the staff that are collect the data could be also to some point problems, like health surveillance assistant that are located in the communities, and also the government structures that like health centers, where the authenticity data that has been collected from these centers of the hospitals might not be accurate as well, because of lack of the machines and technical know-how. And this still remain questionable in Malawi. Another point I want to make is also this a funding gap. The funding gap is one of the challenging in Malawi. And this funding, we have a short-term funding which is funded by UNICEF and WHO and other partners. And this funding is only funding comes on the response, only on the addressing the problem on that particular moment, but not looking at the wider how that problem will be addressed. And the involvement of such kind of activities, it was only the government and the international NGOs. As you may be aware that the point of localization right now as a means of taking the all intervention to the communities the local organization has never been participating in such event, because there are even also the NHS like the WHO, UNICEF, they did not approach the local organizations that they could have also able to get the accurate data. At the moment, it's only international NGOs involved in such intervention. So we have seen that that report is very good, but they need also to consider the upstream of funding to local organizations, and as well as the international organization should build the capacity of the local organization in order to get accurately data that we might require. There's also some issues I wanted to talk is like the issues of vaccine. You know, we pre-tested the vaccine of cholera outbreak in Malawi, and the cholera was not available. And why cholera was not the cholera vaccine was not available, because we pre-test if it is working or it's not working, but we did not get the results. After the cholera outbreak vaccine has been rolling out to the country, what impact and what are the implications of this particular cholera? And what is the IFEs and what is the other health implication to the communities? And that also has come up with as one of the challenge that WHO and UNICEF should also increase to address that. And if we want this, we need to plan earlier. Another last point I want to make is on the preparedness. Most of the interventions in Malawi, they go into the preparedness, but they don't want to look about the recovery implications. So the recovery implication in Malawi is the largest cost. Actually, as you may be aware that Malawi has the economy in a crisis, and is most of the health centers, there's run out of vaccine, even other essential medicine. And as such, because of the cholera outbreak, has increased an alarm of WASH intervention, not in a short term. But this WASH intervention must be a holistic, not as the partially on the health centers or in schools only, or in only communities, but wherever people are, they must intensify WASH activities. This WASH activities, including hygiene and water sanitation and hygiene practices, would be the largest area where they need to invest to make sure that people should know about hygiene and hygiene practices and sanitation practices to use the means of preventing the cholera outbreak. As you may be aware, cholera causes its poor hygienic and the lack of sanitation in the communities, where people did not have a safe water, people did not have a good toilet, people did not have facilities that they might help themselves to prevent on a such particular aspect. However, as we may appreciate right now, we have, as a country, developed the policies, and these policies has been helped by my colleague here, WHO has supported, UNICEF has supported to develop the cholera policy outbreak, that we need to put a mechanism, not only the time when the event was happening, but even throughout the year. What is our plan when such emergency will happen, and how do we address these things? And I know that I'm part of the participating on a healthy cluster, social protection cluster, the WASH cluster. I understand we discuss these things at over there, but only the people that make a presentation is only the agencies and international NGOs. It has already displayed that we need to make sure that local organization must be highly involved, and even also the community is highly involved, and putting a very strong structures in the communities to make sure of such emergencies and such preparedness. People are aware and how they're going to protect themselves. So
Wonderful.
This is what I can say at the moment, and look about a lot of things that happens in Malawi, and even a global trend. The funding for WASH becomes raw, and the capacity building for WASH, and in terms of the people who are involved in such particular intervention, is also low. So we need to make sure that if you want to move as a global village, we should think about big, and think about how are we going to mobilize the resources to prevent over such kind of things. If it comes to attack the whole world, what will happen? That will be the whole issue that we need to think about. Thank you.
Thank you very much,
Manisha.
Stanley. And I think you raised a lot of issues that were found in the report, but also Henry, that you raised in terms of the lack of accurate data being there, the fact that we're not making those investments early on. What can we do? And I'm going to ask this question to all three of you because we don't have any questions in the chat yet. What is it that we can be doing to really galvanize governments to be investing in that preparedness, to be investing in that wash and sanitation, so that we're not, as you put it, only responding too late in a way, like nobody should be getting cholera in 2023. What can we do to sort of shift the approach so that there is funding going towards preparedness and prevention? I'll come to each of you. We've only got 5 minutes left, so. And then if you have any last words, throw it in there when you come back with an answer too, if that's
right.
good.
I think
Stanley
there are
first,
so
then I'll
many
come to the
ways.
other two.
Great, Manisha. There are so many ways. The only problem that as African countries and Malawi in particular, we advocated to make sure that the government should take wash as the most important interventions. But when it comes to the funding allocation, it seems that this year allocation becomes very sympathetic, and there's no adequate resources because most of the intervention in Malawi, we are depending on donors. And the donors largely support intervention like WHO, UNICEF, UNDP, UN Women, to support men and many agencies, to support such kind of interventions. It has never come very clear to have a very good allocation to maybe 10% or 12%, according to the declaration of the government that have declared that at least 10% of the allocation of the funding of the government must allocate to WASH. It has never happened. So I feel that even though we have done a lot of advocacy and budget analysis on the health sector, on the WASH sector, just to bring people to understand that this is a very important area, but it's still more, it's under allocation.
Super. Thanks very much, Stanley. I'm going to, thank you. Wonderful. Henry and then Nigel, or Nigel then Henry, whoever wants to come in, what should we change in addition to what Stanley just said?
I think we need to build a better business case, and so that we basically show that this, we shouldn't be responding, we should be preventing. That there is not only it's not only cholera that is going to get sorted out with investment in water and sanitation, but a wide range. Look at the development goals. Look at the economic benefits to infrastructure investment in these cholera affected countries. But we also need the political buy-in from governments to ensure that data is shared, so that we are then better able to target those areas that are hotspots, and we don't use the phrase anymore, but basically cholera hotspots, to reduce the cholera burden, drive down the CFR back to something that is more acceptable to the less than 1%. Over.
Thanks so much, Henry. Nigel, and just for anyone, CFR, case fatality rate, in case somebody didn't know that acronym.
Great. Thanks, Misha. I think one of our main findings was we need to move much more to a risk-based approach. So quite often there were delays in response whilst people were waiting for confirmation, but during that time, things expanded and got worse, and therefore more expensive to control. So we know what all the risk scenarios are. When we see a high risk scenario, intervene earlier. And I'd like to highlight the work of Integrated Outbreaks Analysis Unit in UNICEF, which are looking at good enough data and using common sense in the say of putting together different stories of people's behavior and the data that is available, rather than waiting for the gold standard and taking a risk-based approach. And then the other things were invest in ORS. We seem to have lost our way with ORS, but it's super effective, super cheap, very easy for people to administer without medical training. And finally, more research into CATI. A lot of our respondents said that the sort of case targeting approach seemed to be effective. But again, that relied on early intervention. So taking a risk-based rather than waiting for confirmation-based approach.
Wonderful. Thanks so much, Nigel. Huge thanks, Nigel, Henry, and Stanley for those interventions. And I think you've all really highlighted the fact that we are not putting the investments in at the right time. We're doing it too late. We need to be looking much more at investing in water and sanitation. Governments need to be prioritizing that. Donors need to be prioritizing that. And it's not only about working through international organizations or the UN, but also working with local organizations and communities so that they're involved, that they can contribute to the data, and that we're able to really do those investments in preparedness and prevention much earlier on, so that we are able to drive down the case fatality rates, particularly as climate change is coming up, making sure that we are putting the investments in the right places so that we don't see the numbers spread even further. I've dropped the link to the report in the chat. Huge thanks to UKHIH and the Humanitarian Outcomes for hosting, and to World Water Week for having us. And once again, thank you, Nigel, Henry, and Stanley for your participation, and thanks to everyone behind the scenes who's helped bring this together. I wish you all a wonderful day. Thank you all.
Thank you, everybody.
Thank you. Bye-bye.